Okay, well, good afternoon again to everyone, and thank you for joining us here at Lighthouse Lab Services for today's webinar. My name is Alex Mitchell. I'm a communications manager with Lighthouse, and I'll be serving as your host for today's event, Billing for Molecular and Genetic Testing, New Trends Impacting Future Reimbursement. Our presenters today will be Ann Lambrix, our Vice President of RCM Consulting, the Vachette Pathology Division of Lighthouse Lab Services. And we'll also be joined by Scott Jones, Senior Operations Manager for AIMA. AIMA is a partner of ours in the RCM space, and we found that they're particularly adept at navigating this complex reimbursement landscape. So if you're looking for a billing solution, there will be opportunities to provide contact information and schedule a follow-up call with them. And we really want to thank Scott today for taking the time to join us. Just a few housekeeping items before we get started here. You can reduce your chance of buffering by closing any bandwidth-heavy apps you might have running in the background. This webinar will be recorded, and a recording will be emailed to everyone who registered after the event, so no need to ask for a copy of slides. If you have any questions throughout the webinar, you can go ahead and drop those right in the Q&A box. We will try to respond to them as we are able, and if we are able to provide a response during the webinar, we will publish those questions so that they become visible to the rest of the audience. Anything we don't have a chance to touch on during the event, we will have a brief Q&A section at the end. So feel free to pre-populate that box, and we'll try to touch on those at the end. And we'll also be running polls during this webinar, and we encourage you to participate in those. Just helps us get a better idea of our audience and some of the needs that they need. We also have a number of handouts that further describe our services if you're interested in downloading those PDFs. And there, like I said, there will be a couple of opportunities to provide more information about yourself if you'd like to schedule any follow-up calls with ourselves or AIMA. If you see those forms come up and you want to open them but fill them out later, they will be available to fill out at any time. And just a little bit about us at Lighthouse before we get started here. We were founded in 2003, and since then, Lighthouse Lab Services has become the nation's leading and most trusted end-to-end full-service medical lab consulting and recruiting firm. And we've had a really exciting year, too, in terms of growth. We've acquired a couple new companies in the spring. Vachette, who Ann leads the day-to-day operations for, is now our RCM Consulting division. And just a couple months ago, we acquired the Burns Consulting Group to offer managed care contracting strategies. So we're really excited about all the growth that we've undergone and the new things to come for us in the coming year. And with that, I'll turn it over to Ann.
Thanks, Alex. Yeah, exciting times with all the change, and we are certainly pleased to be part of the Lighthouse team. This topic, billing for molecular and genetic landscape, or the genetic testing, I did want to talk about the current landscape and again, just the craziness right now with billing for molecular and genetic testing. Right now, there is variances by state when we look at Medicare and Medicaid as far as reimbursement. Depending on what Medicare MAC you're in, you could see some differences with the type of policy that is being administered. Same with Medicaid. Your state Medicaids may have differing policies. To simplify and say, well, if they're, if Medicare pays for this, then I should be able to get paid for this. It really, unfortunately, is not the case because it does depend on what state that you're in. Looks like we're getting a poll, if you want to go ahead and answer that. Again, and when you get into billing commercial payers, there's multiple policies by payer depending on the product type that United Healthcare has. United Health Commercial, Medicare, Medicaid, and to again believe that because the United Healthcare Medicare is paying according to Medicare is going to be the same for a commercial plan. That is also could not be true as well. Limited coding guidance from the payers. Limited coding guidance from the payers. Again, when you get into billing commercial payers, there's multiple policies by payer depending on the product type that United Healthcare has. United Health Commercial, Medicare, Medicaid, and to again believe that because the United Healthcare Medicare is paying according to Medicare is going to be the same for a commercial plan. That is also could not be true as well. Limited coding guidance from the payers. There's limited coding for these type of testing as this develops, and they add new CPT codes to be more descriptive in the actual test that's performed. So that allows for some discrepancy or some confusion because of the use of, again, we have codes like 81479, which is a generic CPT for unlisted procedure, which is reimbursing zero. There's the 87798 on the molecular side, where again, a generic CPT that is applicable when you are unable to identify a particular pathogen that has an assigned CPT code. So again, the coding guidance and the reimbursement, you see a lot of question marks. There's also laboratory management programs such as AIMA and EviCore, United Healthcare, Anthem. They all have, again, depending on the products and the state that you're in, you may have different laboratory management programs that you need to work with for pre-authorization, as well as the clinical guidance of medical necessity of the test that you're performing. So it's confusing. There's just a lot of differences in reimbursement, and it's difficult for labs to fully understand, again, when they enter into this arena, how do I bill, how do I get paid, how do I remain compliant? So again, I wanted to just look at what we do as far as evaluating your billing model and what we would recommend, again, because there's so many differences depending on what your payer is. You really need to understand your payer mix. What are the patient population that you're tending to target your testing to? Are you participating with those plans? And if you are participating, what is your contracted rate? If you're not participating, do these plans pay out of network? We do see where many plans will not provide out-of-network benefits for out-of-network laboratories for this type of testing. Or the patient receives a large out-of-network, out-of-pocket, so it ends up being the patient footing the bill. So looking at your out-of-network policy, and again, your billing compliance and patient billing compliance is important, dependent on your participation with plans in your area. And then the final step, obviously, is looking at that front end. If you are billing to Medicare or United Healthcare, what types of pre-authorization or validation needs to take place, depending on that state or the MAC that you're in, to ensure that your tests are registered appropriately, receive the authorization for the lab to be completed, and potentially pre-authorization for the patient to receive the test. And that's important to understand and have upfront strategy to ensure that the claims are flowing through. You're getting those steps upfront in order to bill out the claim and get payment on the back end. And there's another poll. I always recommend to do your homework and check your answers twice. So because of the varying policy, and there a lot of information, or maybe I would say lack of information, to validate, am I doing this correctly? Am I interpreting this rule correctly? It's important to understand those payer policies, coverage limitations, and I like to check those answers or bump it up and validate with another resource. So again, I work with Scott with clients and using my resources, such as billing agencies that we work with, the clinical team on the lab side, to make sure that we're all on the same page as far as our interpretation of the policy is super important, and making sure you all come to the same conclusion. MolDX and understanding, again, the program rules and limitations and the diagnostic exchange. Again, if you're within the MACs that participate in MolDX, it's important to be evaluating that on the front end and understanding those LCDs that will guide on the appropriate billing as well as the reimbursement limitations. Medical necessity, there is clear guidance with most plans on what they deem as medical necessity. And when I say clear guidance, you can't see that I'm rolling my eyes, but again, from a billing perspective and not being a clinician, reading and trying to interpret some of the very lengthy policy guidance, it gets very confusing, and that's why, making sure that you're checking your answers and your understanding with another industry expert is important. And then what does a payer say about NGS testing? Is this something that, again, they find medically necessary? Are there limited tests or diagnosis codes that they would deem medically necessary to perform this type of testing? Again, is important to evaluate. And we talked about guidelines for submission, and Z codes really is part of that MolDX program and the diagnostic exchange, making sure your billing team or your biller understands the application of those Z codes. If you are part of those MolDX MACs, those Z codes are required to be on the claim submission. So again, these are all things that you need to do up front, or evaluate if you are performing this testing, making sure you're going through this checklist and making sure that your answers, you understand these bullets. So I like to shake my crystal ball and try to understand what the future landscape is looking like. And I know Scott is going to talk about some recent changes with articles and potential draft LCDs that we are seeing. But again, at high level, what we see now is throughout the U.S., there are 4 MACs that are participating in the MolDX program. Those MACs are CGS, WPS, Palmetto, and I'm missing one, the big one. Scott, what is the one I'm missing?
I think it must be, you covered Palmetto.
Yep.
Then we have WPS and
Did you say Noridian?
Noridian, yes. Thanks,
Noridian.
Alex. Noridian. So yeah, the West Coast are all part of the MolDX program, which whether we like it or not, the MolDX program does provide, I would say, guidance for those MACs. The LCDs are same across the MAC, and so there's consistent application. So we still have 3 MACs that are not part of the MolDX program. And what we're seeing, especially in Novitas, is that we are seeing some new article or new communication, which leads me to believe that there may be some additional alignment into this program. Again, the three MACs, Novitas, we've got First Coast, and NGS that are currently not part of the MolDX. I believe WPS came in around 2017, 2018. So it's been a few years since we've seen any new MACs roll in. And again, based on the newest articles, some changes in policy, I wouldn't be surprised if we see some more rollout within the next, I would say, year or two. Same with laboratory management. I continue to see more utilization of programs such as EVCore and AIM, where payers are outsourcing these programs to a high-level program where, again, you see more consistent guidance, and they're not managing the individual policies for the payers are not managing the individual policy and the authorization. We're going to see that be more condensed into these laboratory management programs. Again, we will potentially see stronger coding guidance. When Scott talks about the new article utilizing, we would call it stacking the tier 1 and tier 2 codes. The tier 1 codes provide more descriptive. The test itself is the CPT code, or the panel is that specific panel CPT code, whereas the tier 2 codes are general codes arranged in order of complexity. So the 81400 to 81408 would be the tier 2. I believe that we'll see increased tier 1 codes allowing for very specific assignment of the CPT code depending on the test that you're performing. And then again, hopefully more descriptive policy regarding medical necessity. So you're going to see where there will be limited diagnosis for medical necessity of these panels. And I would say what I believe will be coming again, and you'll see in the next couple slides, the discussion regarding new article language for Novitas, but large panels with hundreds of genes tested for, we'll start seeing that the payers will be cracking down on those, and they will want more patient-specific or patient-centric testing. And so that's why you're going to see a narrowed diagnosis range. And I see AJ had also replied, Noridian, thank you. I was just making sure everybody was paying attention. All right, so I'm going to kick it off to Scott to talk to us a little bit about the LCD changes affecting genetic billing.
Thank you, Anne. Hope everyone are able to hear me. Good afternoon. My name is Scott Jones. I'm Senior Manager of Operations with AIMA BMS LLC. So we have been providing billing services to physician groups and labs across the nation. And when it comes to labs, we have primarily focused on independent labs, and we work with labs of all sizes and shapes and specialties. We bill for multi-specialty labs, genetic labs, toxicology labs, and even pathology groups. And we have been specialists on this domain since 2015. With that introduction, I would like to bring everybody's attention to this new changes that are coming in Novitas as well as on First Course, where these were the two major MACs which were not participating with MolDX program. So there was some revenue potential, but with the introduction of these new LCD articles, the labs are going to be more dynamic in terms of how tests are ordered, how tests are performed. So I'll just go a little into detail of this. So this article A58917, which is named as billing and coding, molecular pathology and genetic testing. So this article always existed, but with this new clarifications added, what payers, especially Medicare, when it comes to articles, we are speaking about Medicare, of course. So Novitas expects genes to be ordered serially. If you are billing for multiple genes, the ordering should be done serially. So when we speak about serially, there should be a reflexive component in the ordering. So what does it mean by reflexive component is nothing but the physician's decision to order one gene after the other will depend on the result of the previously ordered gene. So that's one important thing to be noted. So we really have to look at the requisitions that each lab is producing currently to see how this ordering can be facilitated. So that's an important piece. Then, as we all know, like when you are running a NGS test, you run genes parallelly, right? You run a panel. So this is where it becomes important that labs understand how to code this going forward, because when you add a 59 modifier, it actually tells the Novitas system that you are actually running genes uh, serially. So you really have to ensure you are using this modifier appropriately, so that you are not breaking any rules that are set forth by this particular article. The most important thing is the new documentation requirements that have been put forward. Basically, it simply does not. It is not about you having the requisition where the doctor has signed a requisition with a order for a panel, but it may not always work. But with this new documentation requirements, you need deeper level of documentation where the the particular gene that the doctor is wanting to test, it also has to be recorded in the history and physical of the patient, or that particular soap note for that encounter where the doctor made the decision to order this panel. So that is a big change. We always had this requirement that documentation should be strong, but in this article it is more descriptive, where they say that the ordering physician should have at least 2 E&M visits with the same patient. So basically, that should be a PCP or a treating physician. So the previous documentation said it should be the treating physician. Now it is more clarified that there has to be at least two E&M visits with the same physician. Then we have the requirement for the patient's notes, history and physical, be it a consultation note or a SOP. It should have the doctor's intention to actually uh, the doctor's intention should be recorded on the notes, as well as another thing that is coming up as a requirement is the doctor should be knowledgeable enough about all these genes that are being ordered. So the doctor who's ordering the test should really well know how these genes will results of these genes will impact the patient's further medical diagnosis and treatment. And most importantly, this particular article comes into effect by November 8th, 2021, which is like a very short time. And it is very important that labs reach out to knowledgeable billers, knowledgeable consultants who can actually help them to understand this whole LCD change appropriately and be dynamic in changing their workflows and their educations to the physicians, uh, the way they run the test, whether you want to run NGS or you want to move to any other methods like Sanger or PCR. All these are considerations that labs should think about and pivot wherever it is required. Uh, Let me move to the next. Yep.
Well, Scott, this is Ann. So can we just again, if I'm a genetic lab in Novitas Mac,
Mhm.
when you say ordering genes serially, parallelly, I'm saying that wrong. So what is the difference running in parallel versus non-parallel? So how is that going to impact our coding?
So when you say running serially, it means one after the other. When you
Right.
say parallel, you are running everything together. So NGS testing in general will always run these genes parallelly. And even if you look at that particular LCD article, it clearly says that if you have run multiple genes on a same data service, it will be considered as run parallelly unless you uh, append it with a 59 modifier to say that this was not run parallelly, it was done serially. So by default, if you build it, it will be taken as the panel was run as a panel, and it was run as uh, basically as a single panel.
And so what if I don't have a single panel, there's no CPT code to assign to the particular panel that I'm running? Would we then have to default to that 81479?
Right now, it looks like we may have to do that.
Mm-hmm.
Yeah,
Which,
we may have to move to 81479 unlisted molecular pathology code.
right, unlisted, and the reimbursement for that is 0. So that's why this is a significant impact to the industry, correct?
You're right.
Mm-hmm.
Again, adding to that, one more thing I wanted to. I mean, this requirement was there with private carriers, but right now it has been with the implementation of this particular LCD, that we have to give the name of the particular gene that we are billing for. When we are billing the tier 2 codes, you have to report the name of the gene on the descriptor. So
Right,
that's an additional requirement that has come up.
right. So again, for our audience, what my understanding with what Scott is saying is so if you're billing those tier 2 codes, which is the 81400 to 81408, we have to then on the claim submission indicate what gene you are billing for. And that is a change that you will need to look at changing within your system so that you're appropriately submitting your claims effective November 8th. And that would be specifically for our Novitas MAC. Is that correct, Scott?
Sorry, Ann, what was the question?
So for this change where we have to add the gene, if we're billing the tier 2, is that specific to Novitas or is that across the board with all MACs?
So we have to be only worried about Novitas and First Coast because MolDX program, the MACs that are governed by MolDX program, they already know what we are billing because we are billing with the Z code.
Right.
So this is only about Novitas and First Coast.
Good. Okay.
So moving on, and I would like to bring everybody's attention to the new article that has been come up with pharmacogenomics testing. This one is at a proposed stage. It's not yet finalized. It does not have a effective date. This is a positive change with PGX testing because right before this particular article, we had coverage for a small number of indications for PGX testing. So when it comes to 81225 or 81226, you had coverage only with psychiatric conditions or a cardiac condition. Now with this new LCD policy or article, Novitas is extending that to a wide variety of diagnosis codes. Some of them are related to gastroenterology, some of them are related to psychiatric, cardiac, pain medications, even malignant hypothermia. So there are a number of indications that have been added. But with that, what Medicare has done, as Anne rightly said in the beginning, they want it to be more patient centric, where if a patient has a problem with psychiatric problem and is in consideration for psychiatric medications, uh, Medicare wants you to bill only for that particular CPT and gene. So in this case, the doctors will have to actually provide you with what particular medication is being considered for that patient, and you will have to report that medication in consideration in loop to 2400 when you bill the claim. So this is more patient-centric shift to the old pharmacogenomics testing. So nobody will be able to bill uh, for CPTs and genes which are nowhere related to the patient's care. So this is a positive shift if you look at from a medical necessity standpoint, and there are more coverage for drugs to diagnosis code correlations, right? And again, the same documentation requirements that we were speaking about in the previous article, the documentation is very important, and the physician should provide what drugs are being considered. Like if a patient is having an adverse reaction to a drug, then those drugs have to be uh, provided with the requisition. And if he is considering the patient to be started on a new medication, and he wants to see whether that will be a good fit for the patient's metabolization, then those have to be given as well. So as Anne rightly said, it is getting more and more patient centric and more individualized treatment. Last one, this is article DA 58795. This is again in the proposed stage. This is for cardiovascular diseases, genetic testing for cardiovascular diseases. I know that some of this our genetic labs have been working on this kind of panels. So basically, this is currently as this proposed LCD stands. This is considered as they say that it is medically necessary, but at the same time they think that the genes that are being tested right now and the CPT codes you will be billing like 81439 or 81413, they are not being covered by Medicare. So I hope personally that this proposed LCD, when it comes into effect, Medicare will be adding more clarity as to why they consider it as medically necessary, but they don't want to cover the CPT codes that are actually assigned by AIMA for that kind of testing. So that's where we are with these three LCD policies, where one is already coming into effect by November 8th, and other two are in proposal stage. And especially with the cardiovascular disease testing, I would expect Medicare to come back with telling us how exactly that needs to be built, because right now whatever AMA has provided us CPT codes, they are being considered as not covered as per this proposed LCD. Yep.
All right, thank you, Scott. I think with that, we'll turn it back over to Ann to close.
Yeah, thanks, Scott. I think for just closing up, you can hear the complexity, and I've been seeing some of the Q&A is coming through. My final thoughts was you need to have partners. If you are doing this type of testing and wanting to bill insurance carriers, it's really important to have partners, especially, I would say, a knowledgeable biller that has experience billing with molecular and genetic tests. Because they can be a support to you as you again submit claims, and making sure that things are coded appropriately, that we're exploring these policies and ensuring that we're all aligned with the changes and what the lab needs to do to adjust. Obviously, we would recommend auditing billing performance. That is something that I always recommend to our clients, is to look at these panels, and we put together an analysis looking at the coding and what we would expect as far as reimbursement and what policies going into the LCD, or if there's a particular insurance plan that you're billing to, what policies we feel are limiting that reimbursement, and then circling back and making sure that once we say and we all agree that yes, this is what we feel we should collect, then auditing that and making sure that that is in fact what's happening, or what types of denials are you getting, so that you can fix that front end, so you're not billing for months and not collecting anything. And we do see labs that happens to get bad information, and then they're not receiving any payment because something was missed as far as a policy or the upfront setup. And then again with the reimbursements, and going back to that first couple of slides that I had, and making sure that when you do your due diligence of this testing, does your reimbursement expectations and that model meet with what is actually happening? And then the final thing, I think this is probably obvious for everybody, but I just wanted to throw that in. The LCDs that Scott mentioned that are in draft proposal, there is a comment period, and labs and anyone really can submit comments during that period. And it helps for the lab to be able to again communicate to Medicare why this testing is they feel medically necessary. It's clinically necessary. Helps for the treatment of the patient. I always say that on the clinical side, we're about 10 years ahead of the payer side. They take a long time in turning the ship, as far as we know that this is valuable testing, but as far as how they see it and how they reimburse it, most payers are not necessarily aligned with that. So it's important to participate in those comment periods if you can. All right, Alex, back to you.
Yeah, thank you, Ann. And I know you mentioned seeing a number of questions in the Q&A section, and I didn't know if there were maybe a few of those that we could touch on if you and Scott are able to view those right now. I just want to put out the standard disclaimer for everyone. We're not going to be able to touch on every question today, and some of these may deal with specifics for your lab that we don't want to provide a generalized answer for. But I do encourage you, if we don't respond to your question directly right now, to please follow up with us. You can use the phone number or email address listed there. either of the pop-out forms that were presented earlier, and we will absolutely follow up with you. So
I'm just gonna maybe ask some of these questions, Scott. I'll try to answer a couple, but again, the couple of the LCDs that you talked about, one of the questions was, is this only for Novitas? Yes, Novitas, and did you say First Coast as well?
looks like Scott
I'm sorry,
might.
I was
there you go.
unmuted. So I've seen the similar LCD in First Coast. So basically, whatever is there in Novitas, that is being mirrored in First Coast as well. So
Jeanette Gray had a great question. If we're in Novitas, should we start adding our tests to obtain Z codes now? I don't think so. Unfortunately, I don't think you'll be able to. I think it will just end up getting some sort of weird denial from Medicare if you're adding your Z codes, or you won't be able to obtain them. Basically, it's not linked into the diagnostic exchange. But it went on to ask, is United going to require Z codes sooner than Novitas may roll it out? Which is a good question, because we have seen where United Healthcare is now, if there is no specific LCD, Scott, correct me if I'm wrong, but if there's no specific LCD, then they are mirroring the MolDX policy, correct?
Yeah, that is as per their Medicare Advantage policies. Any Medicare Advantage plan, they will use the MolDX LCD if it is not available in the MAC from where you're operating. So that we have seen. I remember UHC actually starting to require Z code for their Medicare Advantage plans. So we are actually working with our labs to actually get this set up for them.
So it sounds like they are currently requiring those Z codes.
Yep.
Novitas is not, and that's the challenge. If you're operating, and billing United Healthcare, you have to align with United Healthcare policy, which is going to be different than your Medicare policy.
Exactly.
And I see Gary Kenny, you asked, are tests provided in non-MolDX Max reimbursable? Yes, dependent on the LCD and what you're billing for. So I know that's a very blanket answer, but yes, you can get paid in non-MolDX Max. I'm just kind of looking for some ones that I know I can answer. Gordon, I see that. Any idea that WPS will roll out this policy? WPS is part of MolDX. So they have their own, again, that's what I feel at some point all MACs are going to roll into, is the MolDX program, which is, this is pretty much their policy, the way that this article is reading. I don't know if you can see these questions, Scott. I think that some
Dr.
of these
had one question. Can we test for more than one drug at a time? Yes, we can do that. That's not a problem at all. We can test for more than one drug, provided it is supported by the documentation from the doctor's side. I'm just going through.
So Julie Kynes, and I apologize if I'm butchering your last name, I'm phonetically reading it, but what do you think of the future reimbursement for whole genome sequencing look like? What will that look like? So again, I would think that right now with payers for whole genome, they're not, for running the sequencing and resulting, payers are not right yet aligned with reimbursement for that. So it's going to become more of an ethical decision if you run that but don't result back all the information. So I would hope that, again, in the future, so the future meaning within the next 10 years, we see more movement on the payer side. And again, involving yourselves in that decision-making on Medicare side in support of why it is such a benefit to the patient to do this type of testing.
Yeah, thank you both, Scott and Ann, for touching on all those questions. And I know, like we said, we don't want to put you on the spot for everything right here. Again, I encourage you to follow up with us. I did see one from Ben that I wanted to address really quickly, asking if we have any upcoming webinars or thoughts on the proposed LCD DL39038, the NAAT panels. I just wanted to say from our perspective, we don't have an upcoming webinar on it. But Scott or Ann, anything we can say to that LCD?
This is a MolDX LCD, right? This
Mhm.
particular one is a MolDX LCD. I have not looked at that in detail, but we'll be able to get back after checking on that one.
Okay. Yeah. No, thank you. So, Ben, feel free to follow up with Scott for a more in-depth answer on that. And unless there was anything else, Ann or Scott, that we wanted to touch on, I think we're good to go ahead and wrap up.
Thanks, Alex. Thanks, everyone.
Okay. Thanks again to
Thank
both
you.
of our speakers, and thank you to everyone for joining us today. A recording will be emailed out later this afternoon. Thanks again.